Hello, everyone. Good afternoon, and very welcome for another webinar in the series Lessons in Bronchiectasis. My name is Michal Steinberg. I'm a pulmonologist from Haifa, Israel, and a member of the Embark Management. And today's topic is the diagnostics of PCD, and it's a real treat to have a speaker and discussant from Dundee. And I'll go on to introduce our discussant, who is Professor Amelia Shoemark, one of the best-known cilia experts and a member of the Beat PCD consortium. And I think she'll be the perfect discussant for this topic. And before I hand over to Professor Shoemark to introduce our speaker, Dr. Emily Howieson, I'll just want to point your attention to the translation option, and the instructions are available on the screen now. Through the Zoom, you can hear the talk in your own language. So with that, it is my great pleasure and honor to introduce our discussant for today, Professor Amelia Shoemark from Dundee.
Thank you, Michal. I'm excited to be here and hear what Emily has to say today. So I'd like to introduce Emily Howieson, who is a scientist who does the diagnosis of PCD at the Royal Brompton Hospital in London. The Royal Brompton Hospital is one of the larger centres for PCD diagnosis in Europe, and Emily has experience across the whole range of diagnostic tests that we do, has been doing this for a number of years, and it's a real pleasure to introduce her and hear what she has to say today.
Okay, thank you. So I'm going to talk about the diagnosis of primary ciliary dyskinesia. So PCD is a rare genetic disorder which affects the motile cilia. So the motile cilia are actually found in several different organ systems throughout the body. So they're found lining both the upper and lower respiratory tracts and the eustachian tubes. Motile cilia are also found in both the male and female reproductive systems. In females, this is in the fallopian tubes, whereas in men, it's in the efferent ducts. And in addition to that, the sperm flagella also has a very similar structure to motile cilia, which is what it uses to move. Motile cilia are found within the embryonic node, where they are responsible for determining left-right symmetry. And finally, we have the motile ependymal cilia in the ventricles of the brain. As the motile cilia are found in all these different organ systems, PCD is considered to be a multi-organ disease, and patients with PCD have symptoms arising from these different organ systems. So as the motile cilia are found in the embryonic node, around 50% of patients with PCD have situs inversus. In addition to this, around 10% have heterotaxy and around 5% have congenital heart disease. Respiratory symptoms typically start very early in life for patients with PCD, with many suffering from neonatal respiratory distress. This doesn't necessarily happen immediately after birth, and many are discharged from hospital only to be readmitted again within their first few days of life, requiring respiratory support. Patients with PCD suffer from a wet productive cough throughout their lives, and this is there even during periods of time where they feel relatively well. Recurrent chest infections and chronic inflammation ultimately lead to bronchiectasis in the majority of patients, with almost all patients with PCD having bronchiectasis by the time they're an adult. Patients with PCD typically suffer from chronic rhinitis and sinusitis throughout their lives, and again, the rhinitis is typically present even when the patient feels quite well. Both these upper and lower respiratory tract symptoms typically become more severe in adult patients, in contrast to recurrent otitis media, which is more predominant in paediatric patients with PCD. These recurrent ear infections often lead to undiagnosed children having grommets fitted, but they continue to suffer from otorrhea after these have been put in. These recurrent ear infections often lead to a persistent hearing impairment in these children, which can be severe. In rare cases, the primary cilia or the motile ependymal cilia may be affected, in which case the patients may suffer from symptoms such as hydrocephalus, hepatic or renal disease, or retinal abnormalities. But these typically only affect a very small number of patients with PCD. Infertility has been reported in both male and female patients with PCD, but there hasn't been a huge amount of research into this, and studies have typically been quite small. However, one study reported that 37 out of 49 males and 22 out of 36 females had problems conceiving. As many of these symptoms are quite non-specific, particularly if there are no laterality defects, PCD often isn't considered as a potential cause of these symptoms, and therefore many patients either go undiagnosed or get diagnosed at a later age. So now that I've given you a brief overview of PCD, I'm going to go straight into my first case study. And I'll talk through the diagnostic procedures as we go through. So my first patient is patient A. So patient A is a 25-year-old Pakistani male. He was born in Pakistan but moved to the UK when he was 15. His parents were both first cousins. He was a very keen sportsman. He played a lot of football, and it was actually through his local football club that he underwent cardiac screening, and they suspected that he may have situs inversus, so he was therefore referred to the cardiac team at our hospital. When his history was being taken, he said that he had a wet productive cough and rhinitis, and he'd had these for as long as he could remember, but he'd never sought medical attention about them. He also reported that he would have intermittent hemoptysis, but as this typically resolved by itself, again, it was never anything that he'd sought medical attention for. On X-ray, it confirmed that he had situs inversus totalis. He also had bilateral streaky markings with possible evidence of bronchiectasis. On a CT, they found that he had severe cylindrical bronchiectasis in the middle lobe and lingula, and moderately severe bronchiectasis in the right lower lobe. So it's mild cylindrical bronchiectasis in his left lower lobe. So as he had situs inversus, persistent respiratory symptoms, and bronchiectasis, he was therefore referred to us for PCD diagnostic testing. So the first test that we do is nasal nitric oxide testing. So nasal nitric oxide testing measures the levels of nitric oxide in the nasal cavity. So it is a very useful diagnostic tool for PCD, as when it is performed using a chemiluminescent analyzer and the velum closure technique, it does have quite good sensitivity and specificity. Patients with PCD typically have low levels of nitric oxide, and as you can see here, the majority of patients with PCD have levels below the threshold. However, you can also see that not all patients do. So you do sometimes get patients with PCD who have nasal nitric oxide levels within the normal range. So it's therefore important to not exclude PCD based on a normal nasal nitric oxide result alone. As well as being caused by PCD, low levels of nasal nitric oxide can be caused by other factors too. So some patients with cystic fibrosis have low levels, can be caused by obstruction such as nasal polyps or even recent infection. it can also be quite difficult to do in young children for them to do the velum closure technique. So therefore in young children, the results are often less reliable as we have to do the test while they're doing tidal breathing instead. So the normal range for nasal nitric oxide is considered to be 77 nanolitres per minute or above. And the low range is below this threshold. Patient A had a result of 9 nanolitres per minute. So this is within the low range and possibly suggestive of PCD. So we therefore proceeded to do our next test, which is high-speed video light microscopy. So in order to do this, we use a small cytology brush to do a nasal brush biopsy and obtain ciliated epithelial cells from the patient's turbinates. So it is a bit of an unpleasant test, but it's very quick. So we then analyse these cells using high-speed video light microscopy. As the cilia beat too rapidly in real time, we're not able to assess the beat pattern or frequency. So instead, we take short video clips, which are then played back in slow motion, so we're able to assess the ciliary beat pattern and frequency. So here, we've got an example of a normal ciliary beat pattern. So when we're assessing this, we want to ensure that the cilia are doing a full effective forward and recovery stroke. You want the cilia to be relatively synchronized. We look to see if debris is being cleared, which you can see occasionally here, as that's the sign that the cilia are moving effectively. So beat pattern defects in PCD can sometimes be quite obvious. So for example, in Altenstein arm defects, you may see no movement of the cilia at all. Or they can be quite subtle. So sometimes the cilia don't show quite a full beat. They may be a little bit stiff, or they may show a rotational beat pattern. And we also look at how quickly the cilia are beating. So if they're beating too quickly or too slowly, that can also suggest PCD. So here we have the high-speed video microscopy results for patient A. Oops. So there's no current international guidelines for high-speed video microscopy analysis. But within the UK centres, we tried to standardise the terminology we use to describe the beat pattern. So if the cilia are showing a full effective beat, we refer to it as a normal beat pattern. If the cilia are a little bit stiff, they're not doing a full bend, we refer to it as reduced beat amplitude or stiff. No movement at all is referred to as a motile, or if there's the majority of the cilia showing no movement, but a little bit of sort of flickering movement, we refer to that as a motile with weak residual movement. So I was wondering what you would refer to this beat pattern as.
So while you're voting, I would like to also remind the chat options, and please use that to place any questions or comments, and we'll read that throughout the webinar, the talk. So I can't see how many have voted, so yeah.
So the majority of you have said a motile with weak residual movement. And that is what we described this beat pattern as. So you can see if the video play again, the majority of the cilia are completely immotile, but if you have a look at the back here, you can see there is some residual movement there. So therefore, we deem this to be motile with weak residual movement. And this is an abnormal beat pattern, and as you can imagine, the patient has a reduced beat amplitude and reduced beat frequency as well. So we therefore proceeded to do our next diagnostic test, which is transmission electron microscopy. So transmission electron microscopy uses a very high magnification, so we're able to assess cross-sections of the cilia. So we're then able to assess the ultrastructure within. So some of the components which are affected by PCD we can directly see. So for example, here you can see the outer dining arms. Inner dining arms are typically a little bit more faint, but here in our control, you can see the inner dining arms. Some of the components which are affected, we can't see, but it causes other effects of the ultrastructure, which we can. So for example, the radial spoke heads or necks and links, defects in these may cause disarrangement of the microtubules or loss of the central pair. Electron microscopy used to be considered the gold standard test for PCD. However, we now realise that 15 to 20% of patients with PCD have normal ultrastructure on electron microscopy. So whilst it is very useful for diagnosing many cases of PCD, it cannot diagnose them all. Here you can see patient A's results. So you can see here there is an absence of the outer dining arms. The inner dining arms, again, are a little bit more tricky to see generally, but the inner dining arms are present in this case. So we can see there's no disarrangement of the microtubules and the central pair is present. So patient A was deemed to have a class 1 outer dining arm defect. So there is an international consensus guideline for the reporting of transmission electron microscopy results now, which is really useful, and it means that what we're reporting is consistent between different countries. So within these guidelines, defects can be considered class 1, which is considered to be a hallmark PCD defect, in which we have much more confidence that this is PCD, whereas class 2 defects, there is less confidence and the results should be repeated and should be consistent between the different tests that we do as well. But in this case, patient A has a class 1 outer dining arm defect, so we are quite confident that he has PCD. So another test that we do alongside electron microscopy is immunofluorescence. So immunofluorescence is quite a new diagnostic test for PCD. So this uses fluorescent labelled antibodies to identify the presence or absence of proteins which are affected by PCD. So here's an example of immunofluorescence testing. So the green staining here is for acetylated tubulin, which just enables us to locate the cilia within the sample. The red staining in this case is for DNAH5, which is our target protein. So this is a component of the outer dining arms. So you can see that when the images are overlaid on top of one another, the staining for DNAH5 is present throughout the full length of the cilia. So in this case, it's present and normal. So this has a similar sensitivity and specificity to transmission electron microscopy. It has the benefit of having a much faster turnaround time, so we can get the results back from immunofluorescence much more quickly. Antibodies are now available for most of the structures which are affected in PCD. And this includes some such as DNAH11, which appears to be normal on electron microscopy. So it is really useful in cases like those. Here we have the results for patient A. So you can see here the cilia are located right here, but the DNAH5 protein seems to be completely absent throughout the cilia. So this is consistent with the electron microscopy results, as DNAH5 is a component of the outer dining arm. So if the outer dining arms are absent, DNAH5 will be absent too. So this supports our electron microscopy results. As you can see, there are quite a number of genes which have now been found to cause PCD. So it's currently around 50. So these 50 genes cover around 70% of patients with PCD. So there are still 30% of patients with PCD who haven't had a gene identified yet, which suggests that there probably are still more genes yet to be found. In this case, our patient was found to be homozygous, but a missense variant of unknown significance in DNA H5. Although this is a variant of unknown significance, because our diagnostic results say they've got an absence of alpha-synuclein arms on electron microscopy, static beat pattern, and absence of DNA H5 on immunofluorescence, this suggests that this probably is pathogenic. Here you can see the number of different mutations which have been reported within DNA H5 alone. So the black dots show loss of function mutations, and the green dots show missense mutations, which are often variants of unknown significance, such as in this case, and therefore require confirmation with additional tests. In 60% of patients with PCD, the genetic variant that they have is unique to either them or their family, which is more than half, and it does complicate the genetic testing for patients with PCD, as obviously if their gene is unique, it's not been previously reported as being disease-causing, which does make it more complicated. So in 2017, there was some guidelines for the diagnosis of PCD published in ERS. So under these guidelines, in order for a patient to be deemed to be definitive positive for PCD, they either need to have a non-ambiguous biallelic mutation, which we don't have in this patient as they had a variant of unknown significance. However, they can also have a hallmark ciliary ultrastructural defect, which in this case we do. So our patient has an alpha-synuclein arm defect on electron microscopy. So we can therefore consider this patient to be definitively positive for PCD. So they received their diagnosis and they're now seen within our PCD management centre. So just to sum up this first case, PCD should be considered in patients with laterality defects. So in this case, it was that ultimately led to the patient being referred to us. However, you do still need to keep in mind that around half of patients with PCD don't have these. Be aware that patients with PCD may underreport or downplay their symptoms. These patients have had respiratory symptoms their entire life and therefore often consider them to be normal, which was the case in this patient. Patients with PCD often have unique genetic variants, and these may be variants of unknown significance, which therefore is why it's important that we do the full range of tests. So this full range of tests that we do to diagnose PCD just helps us to build a diagnostic picture and is important to get an accurate diagnosis, as unfortunately there's no one test which will be able to identify all patients with PCD. So I'll now move on to my next patient, who is patient B. So patient B is a 37-year-old Pakistani female. She has had a chronic productive cough since her childhood and has persistent rhinitis. She had previously smoked from the age of 17, but had stopped last year. However, over the last 2 years, she reported that she had been becoming increasingly breathless. She had 2 children and had no difficulties conceiving these children. On CT, she had extensive cylindrical bronchiectasis with mucus plugging. So she was referred to us for PCD testing, and we started by doing nasal nitric oxide testing. So as a reminder, the normal range is 77 nanolitres or above, and patient B had a result of 297 nanolitres per minute. So I'd be interested to know where you would go from here. So based on this patient's clinical history and nasal nitric oxide result, would you either proceed to do a nasal brush biopsy, or would you exclude PCD due to her clinical history and normal nasal NO results?
Just while people are voting on this, just to say, please do continue to put questions in the question and answer. The discussion's a really important part of this, but we'll answer them at the end of the presentation, or discuss them at the end of the presentation.
So in this case, the majority have said that you would proceed to nasal brush biopsy. So under the guidelines, if a patient has a normal nasal nitric oxide result and they don't have a very good clinical history for PCD, you can deem at that point the patient to be unlikely PCD. However, obviously it's a clinical judgment, and in this case, the clinician felt, as I imagine many of you did, the history was sufficient to proceed. So we went ahead and took a nasal brush biopsy, a higher speed video light microscopy. So just as a reminder, when we analyse the ciliary beat pattern and frequency, we want to see the cilia showing a full effective forward and backward stroke and a relatively synchronised beat pattern. So this is patient B's high-speed video microscopy video. So as you can see, there is a thick layer of mucus surrounding the cilia. And the cilia are showing they're not quite showing a full beat. So the beat pattern could be described as reduced beat amplitude, possibly a bit stiff. In cases like these, it is very difficult, as you can't tell if this abnormal beat pattern is being caused by a primary cause, so primary ciliary dyskinesia, a more subtle form, or if it's being caused by secondary factors. So it could be due to mucus impedance. So it can be caused, secondary ciliary dyskinesia can also be caused by infection or inflammation, or even environmental factors such as smoking. So as this beat pattern is abnormal, we proceeded to do electron microscopy. So again, we want to analyse the ultrastructure and identify if there are any abnormalities within it. So this is patient B's results. So you can see the outer dining arms are present. So there's a presence of the inner dining arms, the microtubules are in the correct location. There's no abnormalities of the central pair. So patient B was deemed to have normal ciliary ultrastructure. However, it was noted that there were some secondary defects that were seen. So secondary defects on electron microscopy can include extratubules, compound cilia, where the cilia kind of merge together, or swollen membranes. So these can be caused by infection, inflammation, or again by environmental factors, or even issues during the processing. However, in this case, the number of secondary defects seen were quite low, so we were happy that the patient had normal ciliary ultrastructure. So we went on to do immunofluorescence. So here we've got staining for GAS8, which is a component of the Nexin links. So here you can see that the GAS8 staining is present throughout the full length of the cilia in our control. In patient B, we can see where the cilia are located using the tubulin. However, you can see that the staining in the cilia is quite poor. There is staining there, but it's similar to the background staining we're seeing in the cytoplasm. So this is considered to be borderline staining, and therefore the results are inconclusive. So with immunofluorescence, again, we can sometimes get inconclusive results if it's an unhealthy sample. However, we can also get inconclusive results in cases of PCD, and it's difficult to determine if this is being caused by primary or secondary factors. Mucus does also cause issues with immunofluorescence staining, as if there's heavy mucus, which we saw in the video there was, the antibodies can struggle to penetrate to get through to the target protein. However, we went ahead and did cell culture. So we use a liquid interface cell culture in order to try and regenerate the ciliated epithelium. So we're regrowing the sample in a nice sterile environment, and cell culture has been found to reduce secondary ciliary dyskinesia and secondary defects that are seen on electron microscopy. Interestingly, it does also exaggerate many cases of PCD. So, for example, in DNAH11 defects on a primary sample taken from the patient, it shows a stiff hyperfrequent beat pattern, whereas following cell culture, it's completely immotile. So it is also useful in identifying subtle cases of PCD. So after cell culture, we repeated the high-speed video microscopy results for patient B. And as you can see here, the beat pattern has normalised. So here we are seeing a nice fall forwards and recovery stroke. Cilia are quite synchronised, and we had a normal ciliary beat frequency. As the gasate staining was inconclusive on the primary sample, we then repeated this as well. So here's our control as a reminder, and you can see in patient B, the gasate staining is present throughout the full length of the cilia. So this is also normalised following cell culture. So I'd be interested to see what you think. So under the ERS guidelines, how would you classify this patient's results? So would you consider them to be definitive positive, highly likely, or extremely unlikely for PCD?
So maybe while people are voting, you can remind of the results of the different tests. Okay, let me see this now.
So following cell culture, we had a normal ciliary beat pattern. We had the normal gasate staining, which had also been inconclusive on the primary result. We didn't repeat the electron microscopy results, as although there were some secondary defects there, they did have normal ciliary ultrastructure. So therefore, we considered, as most of you have as well, that this patient was extremely unlikely to have PCD. So they had normal nasal NO and normal ultrastructure. So therefore, the patient is referred back to the clinician who had referred them for them to investigate other possible diagnoses. So to sum up this case, recent infection or inflammation can introduce secondary ciliary dyskinesia and secondary ultrastructural defects. And this can complicate the diagnosis, as it can be difficult to tell if this abnormal beat pattern or potentially the abnormalities being seen on electron microscopy are PCD or if it's being caused by secondary factors. Cell culture is a really useful technique, so we are able to regenerate the cilia, and it can reduce secondary defects seen at high-speed video microscopy and immunofluorescence and electron microscopy. However, sometimes cell culture may not work, may not be successful, or the results may still be inconclusive after a culture. So therefore, sometimes it is necessary to repeat a brush biopsy on a patient and repeat these tests. It's recommended that if a patient has had a recent infection, that you wait 6 weeks before they undergo a brush biopsy, just in order to obtain the healthiest possible sample and reduce the chance of secondary defects. So I'll now go on to my final case study, which is patient C. So patient C is a 17-year-old Caucasian female. She attended the clinic appointment with her mum, who reported that she had suffered from neonatal respiratory distress after birth. And she had continued to suffer from a chronic wet cough and rhinitis throughout her childhood. She was previously treated as having asthma due to some occurrences of wheeze. However, her asthma medication had since been ceased with no adverse effects. Over the last year, she had had 2 hospital admissions for chest infections, which were quite severe and required IV antibiotics. She had previously had grommets fitted due to recurrent ear infections, and she had a chronic discharge from her left ear after the grommets had been put in. To rule out cystic fibrosis, she had had 2 sweat tests and they had both been normal. On X-ray, it was found a left lower lobe collapse and consolidation. And on CT, she was found to have widespread bronchiectasis. This was most pronounced in her right upper and right middle lobes. So, as quite a few of these could be caused by PCD, we proceeded to do nasal nitric oxide testing. So patient C had a result of 15 nanolitres per minute, which is within the low range. So we therefore proceeded to do high-speed video light microscopy. So as well as assessing the side view to look at the ciliary beat pattern, we also analysed the cilia from a top view. So again, as well as seeing cilia doing a nice full beat pattern, we want to see if there's any signs of a rotational beat pattern. So the cilia should move forwards and backwards, as you can see here in our example of a normal beat pattern. In patient C, you can see the cilia are quite poorly synchronized and they are showing a rotational beat pattern. So it's most evident around the bottom here. You can see that instead of just moving forwards and backwards, they are sort of showing a rotational beat pattern instead. So the beat pattern and the beat frequency was within the normal range. But as they have this abnormal rotational beat pattern, we proceeded to electron microscopy. So here's the example of normal ultrastructure again. And here's patient C. So you can see the outer dining arms are present, got the inner dining arms are present. There's no disarrangement of the microtubules. Central pair is present, there's no loss of the central pair here. So overall, patient C was deemed to have a normal ciliary ultrastructure. However, we know that in 15 to 20% of cases of PCD, patients do have a normal ultrastructure on electron microscopy. And this includes hiding, which is a mutation of a projection coming off of the central pair. It's not visible on electron microscopy, not clearly visible. So we proceeded to do immunofluorescence. So here is the control. We've stained for SPEF2. So SPEF2 is a protein which is absent on immunofluorescence, both in cases where the patient has a SPEF2 mutation and when they have a mutation in hiding. So we typically use this if there's any signs of a rotational beat pattern. Here is the result for patient C. So again, we can locate the cilia using the tubulin, and you can see that within the cilia there is a complete absence of SPEF2 staining. So this suggests that the patient may have a defect in SPEF2 or hydin. Proceeded to do genetic testing, and our patient was found to be compound heterozygous for 2 loss of function mutations in hydin. So this is consistent with the loss of SPEF2 on immunofluorescence, so a normal ciliary ultrastructure and a rotational beat pattern. So under the ERS guidelines, for a patient to be definitively positive, they need a non-ambiguous biallelic mutation, which we have in this case. So this patient was compound heterozygous for mutation in hydin. She had a normal ultrastructure, but as she has the genetic mutation, she can be classed as definitive positive for PCD. So again, she received her diagnosis and is now seen within our management centre. So to sum up this case, so consider PCD if a patient has had respiratory symptoms throughout their childhood. So patient C had been in and out of doctor's appointments with persistent respiratory symptoms throughout her childhood. And as these symptoms in PCD typically begin shortly after birth, it's definitely worth considering if a patient has had these symptoms for a very long time. Some PCD defects have more subtle beat pattern abnormalities, and they may have normal ciliary ultrastructure. Immunofluorescence is a new but useful test, and it can be used to detect structures which are not visible by electron microscopy. So in cases of hydin, and it's also a case of DNH11, they appear to be normal on electron microscopy, but immunofluorescence can be used to detect the presence or absence of these structures. So I just wanted to finish on a few take-home messages, really. So the diagnosis of PCD is quite complex. There's no one test which can diagnose all cases, so therefore we have to do multiple tests at a specialist diagnostic centre in order to make an accurate diagnosis of PCD. Infection and inflammation can both cause secondary ciliary dyskinesia and secondary ultrastructural defects, which does make it more difficult, as when we're seeing these defects, it's not immediately apparent if it is PCD or if it's being caused by secondary defects. And finally, so PCD is very underdiagnosed. So if you're seeing patients in clinic who have bronchiectasis along with laterality defects, infertility, or who have had persistent respiratory symptoms since early childhood, it's certainly worth considering if they should be referred for PCD diagnosis, as there are still many patients out there who would really benefit from getting a diagnosis. Okay, so thank you. So have you got any questions?
Thanks very much, Emily. That was fantastic. It's really interesting cases, and you really showed how difficult the diagnosis is. But I think even though it's difficult, it's really important that we do it because it is a multi-system disease where you need input from other specialties as well as from respiratory. In terms of ENT, fertility, genetic counselling, but also because I think we're in a really exciting place for PCD where messenger RNA therapies are actually going into people. There was a paper in the Lancet Respiratory Medicine last week that was announced that the ERS are doing PCD-specific trials of drugs, and I think we're not that far off having PCD-specific therapies, and therefore we really need to diagnose our patients, even if it does take a multitude of tests and expertise such as your own. We've got lots of questions for you in the chat. Mattia has asked, when do you think we should perform full screening for PCD in people with bronchiectasis, and which features should guide us in the identification of the correct patient to test? And you touched on that a little bit at the end, but I think it's interesting from someone who's in a diagnostic service doing the work as well, because it is a lot of work. You know, what's your threshold as to who you would test versus who you wouldn't? And we know PCD is underdiagnosed in bronchiectasis. We see patients sitting in bronchiectasis clinics labelled as idiopathic who have PCD, so we want people referred, but it's a lot of work, and it's costly, and it's often patients have to travel and have uncomfortable tests. So where would you draw your lines as to who to test and who not to test?
It is tricky, as there are like so many symptoms with it being a multi-system disorder. I think certainly if they have infertility problems, obviously if there are any situs abnormalities, I think it's really important if they've been having these symptoms since childhood. As with bronchiectasis, I know a lot of people just develop it as an adult and develop symptoms as an adult, whereas patients with PCD will have been having these upper and lower airway symptoms since shortly after birth. So certainly if these patients have been having persistent rhinitis, a persistent cough throughout their entire life, then it's certainly worth testing for PCD.
Yeah, I guess with the caveat that they underreport as you.
I know they do, which does make it again more difficult, but.
Let's talk. We've got more of a technical question here, which is how many proteins do you test for on immunofluorescence, and how do you select these? Which I feel is right up your street, because you basically did a huge amount of work on immunofluorescence and its sensitivity and specificity in PCD testing.
So we start with a core panel of, so all patients will look for DNH5, the alpha-stein in arms, GAS8, so for, again, next and links, any disorganization defects, and RSPH, one of the RSPH ones, so we use RSPH1 for the radial spokehead protein. So all patients, we use those. If we see any particular beat pattern abnormalities, we might use other antibodies. So if we're seeing a hyperfrequent beat pattern, a range in CBF, a very stiff beat pattern, we'll do DNH11. If we're seeing a rotational beat pattern, we'll typically extend the radial spokehead antibodies that we use. We also use RSPH9, and we also use the SPEF antibody. And then again, we've got many other antibodies which we might use, depending on genetic results. So if they've got any mutations found on genetics, we'll use a relevant antibody then.
So it sounds like some of it's quite subjective, or I know some of it's quite subjective. The high-speed video assessment and the selection of which antibodies you're going to use. One of the questions here was about AI and essentially quantifying and standardizing what we do. What are your thoughts on that, and how we should proceed to make this easier, essentially?
Yeah, so the assessment of the high-speed video microscopy, it does take a lot of experience and a lot of practice, which is why it's done in these in the diagnostic centres. There is currently research going on here and develop AI. So if that is successful, it will be really useful with the subtle defects, so it can be a little bit more difficult to spot. So if we can get this up and running, that would be really helpful. But yeah, at the moment it's more a case of just sort of a lot of practice to become more used to spotting those more subtle beat pattern abnormalities.
There's a couple of questions here about resource limited settings from a couple of people. So I thought it was worth probably between us having a discussion on that. I think that nasal NO has an important place to play, and if you have resource limited settings, then actually usually a nasal nitric oxide analyzer is available. You can use the exhaled NO analyzers that get used in asthma, and they have nasal attachments. There was there's been published this year ERS task force on measuring nasal nitric oxide across all ages, and includes interpretation of some of the smaller analyzers, the analyzers that are more affordable and are portable, and interpretation of those versus the chemiluminescent gold standard. So I think there's a place to play for that in that. I also think that immunofluorescence is really useful in that it's quite simple to do, and it's actually much more cost effective than doing genetics and EM, and the next guideline will probably reflect that. But actually it probably depends just on what resources you have. So some people have good access to genetics and not good access to other tests. In an ideal world, as you say, you want to do all of the tests, and that's probably the best that can be done. I think it's also really important to remember that about 50% of PCD diagnosis is pretty simple. It's the cilia don't move at all, and there's no outer arms and there's no outer and inner arm defects. So you actually can diagnose a lot of people just using some very simple tests, or getting a confirmation by genetics, or getting a confirmation by electron microscopy. What's really difficult is the excluding, because of the huge spectrum of other things to do. I've talked a lot. I don't know what your thoughts are on resourceful settings. I know that you accept samples from places at times.
Yeah, no, I agree. It does depend what you have available. In an ideal world, you do want to do this full range of tests, but if you've not got access to that, I think, like Amelia said, immunofluorescence is really useful, which you just need a confocal microscope, which a lot of places do have. So yeah, that or nasal nitric oxide are definitely a good place to start.
Yeah. Mikhail, did you have any comments? No, I'll keep going through the questions then.
I don't know. Maybe I've missed the answer, but there was also a technical question about culturing the cells before the high-speed video fluorescence.
So yeah, I think that Amelia, do you do that in Scotland? I think you do the culture first, don't you?
Yeah, so we do high-speed video and then we culture, and then if the high-speed video was abnormal first time, then we repeat it after culture, which allows you, as shown in that second case, to see the secondary defects. There is a question here about why cell culture makes makes normal more normal and abnormal more abnormal. I don't know, Emily, do you want to comment on why normal becomes more normal?
So in the samples that we get from the patients, obviously the patients may have a lot of inflammation, they may have infection, which is causing these abnormal results. So then after the cells have been regrown in culture, they've not been subject to that inflammation or the infection. So we don't get the secondary defects that are being caused by the inflammation or infection, which is why it helps to improve secondary defects.
Yeah, so we take them down to a basal cell phenotype and we grow them for 8 to 12 weeks. So they've spent a long time outside the person, and they're essentially different epithelial cells, which but I think it's a fascinating question why the abnormal becomes more abnormal in culture. I don't know the answer to that, aside from there's lots of bits of the body and compensatory mechanisms that are missing in a dish. There's a question from an anonymous person about, has COVID made the diagnosis of PCD more tricky?
So obviously Amelia's done some research into this, and you found during the first wave COVID was causing sort of a more rotational beat pattern in patients who don't have PCD, whereas previously a rotational beat pattern was quite distinctly, like if a patient had a rotational beat pattern, it was likely to be PCD. So it made it more difficult in terms of that. It did also cause a lot of issues with obviously infection control during the initial pandemic. But I think since now people are vaccinated and we got the later strains, I think Amelia's research, I think, am I right in saying we're getting less of those defects caused by COVID now?
Yeah, we discourage people from having a nasal brushing if they've had any kind of upper respiratory tract infection in the last few weeks anyway. So if someone's had an acute upper respiratory tract infection, then we try and postpone the brushing until they're as well and clear as possible in the nose to give ourselves the best chance of having a successful nasal brushing, whether it's COVID or whether it's other viral infections. But it's not always possible, and we do see virus infection, mainly loss of cilia from the epithelium, which means doing the tests is difficult to do.
Yeah, and just to add to that complexity, about 35% of people with bronchiectasis have chronic rhinosinusitis, so that can really complicate matters if you're trying to get a clean, non-infectious sample. So I think for the interest of time, I think we should stop here and thank Emily for a wonderful and very, very exciting presentation, very clear. If you can press to the next slide, there is an overview of the next webinar series. Yeah, so the next webinar in this series is on November 8th, which is the microbiology of stable bronchiectasis. And the next will be about prevention. So please make sure to register for these webinars, and all the webinars, including this one, will be posted on the Embark website. So thank you very, very much for all of the questions and the active participation. And thank you, Emily and Amelia, for the nice presentation and discussion of this case.
Thank you.
And see you all at the next webinar.